Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance record, and also if you could, please remember to fill out the program evaluation, and please give us any ideas that you might have in regards to future topics and future speakers. Speaker today is Dr. Dan Mooney. Dr. Mooney is certified by the American Board of Preventative Medicine and the American Board of Family Practice. He is a certified medical review officer and also certified independent medical examiner. He's here today to update us on the DOT medical examiner requirements, and please join me in welcoming Dr. Mooney.
I'm hoping this thing is working. This can be extremely informal. This talk is predominantly geared toward primary care providers that do the DOT exams. There have been some major changes in DOT examination procedures, some of them instituted, some of them forthcoming. So I thought that now would be a good time to address some of those issues. What's going to happen is there is now a National Registry of certified examiners for DOT exams. In the past, DOT exams have been done by any licensed provider. In some states that varies quite a bit. And there's a lot of different approaches that have been taken by various providers. This is a means of doing a couple of things. One is standardizing the examination, certifying that the examiners are qualified to perform them, and also comes with a whole new set of auditing and credentialing issues. Just to let you know, this all comes under the Department of Transportation, specifically under the Federal Motor Carrier Safety Administration. Well, we can always talk about why you have a new administration to do something, and the reason that this has happened for DOT exams is because there's tremendous variation between what examiners are willing to accept in individuals that are operating commercial motor vehicles. This is predominantly a safety issue, and just to bring it home a little bit, you know, we all drive on the interstates, and when we pass one of these massive semi-trailers, keep in mind that the person operating it has approximately the same amount of force as half a kilo of plastic explosive behind it. So it behooves us all to make sure that these operators are safely operating and physically capable. All the medical examiners who conduct these examinations are going to be required to take a certain amount of training. This is approximately 16 hours of pretty much seated lecture type learning. There is now also some internet-based learning that's been put forward, and I haven't seen it yet, but I hear that it's not too bad and it does pass the requirements. And with any other credentialing initiative, if you will, you're required to pass a test. You're required to maintain and demonstrate competence through periodic testing. The Federal Motor Carrier Administration has already set up the National Registry. It does require that the individuals that want to do the DOT exams and bill for them, of course, must become part of the National Registry. And I think it's May of 2014 that it all comes into play. That requires the examiner to be registered, to be certified, to have passed the test, and then only those individuals be able to deliver those examinations. And again, it is May 21st of 2012 when this all comes into effect, so there's still about a year for individuals that want to do these to be trained. We'll talk just a little bit about the eligibility requirements. This is pretty straightforward. This is pretty much anyone who is licensed by a state to perform physical exams. Eligibility requirements require this training program. Again, it's about 16 hours of lecture. Just to give you an idea, I brought the syllabus of when I took the course. And I'd love to say that this 200 pages is all there is, but this little CD in the back has the other 1,700 pages of things that are covered.
Dr. Mooney?
Yes.
We have a question.
Yes.
Just right off the bat, it seems that could be a crossover in qualifications between aviation medical examiners. Is there any
No,
grandfathering?
there is not. I've done FAA exams as well, and actually the program to become an FAA examiner is a lot more extensive. The other thing about this is in the FAA system you have a whole series of senior medical officers that you can call and help get decisions about drugs that are applicable for pilots. Not so in the DOT. But no, no grandfathering in. This is a standalone training. Why anyone would want to sit through 16 hours of classroom to wait 3 years to take a test, I'll never know. The test, I am assured, has been designed so that those individuals that actually show up and listen to the training can pass it. It's all horses and no zebras. The required training topics are predominantly centered around reducing the issues of crashes. And as you can imagine, when you have the millions of semis on the road and other commercial vehicles on the road, the individual operating that machine has a very big responsibility. And what they're really trying to do is also disseminate some of that responsibility to the examiner. And just as a side note, I would tell you that there has been a successful lawsuit brought against an examiner who passed an individual to operate one of these machines, wound up in a motor vehicle accident, and actually killed someone. Not that that should keep you away from doing the exams, but it has been successful. One of the big things that did not occur before that is now being pushed is obtaining additional diagnostic testing. This is commonly a difficult problem for a DOT examiner because we have no control over the individual. The only control we have is whether or not we qualify them or disqualify them. We can't tell them, we want you to go get the glucose tolerance test, or we want a fasting blood sugar, or we want you to have an EKG or a stress test. We really can't do that. All we can do is say, we don't feel like you're qualified, this is what we recommend. But they are looking at additional diagnostic testing and kind of being responsible for it as a bigger part for the DOT examiner with the new training and the new guidelines. Other topics that have to be dealt with are this idea of educating operators about medications and non-disqualifying medical conditions. They're putting the DOT examiner in a position to function in some regard as the primary healthcare provider for the driver. That's not necessarily a comfortable position to be in when you also may be taking away their ability to make a living if you don't qualify them. But this education has become something that must be documented now on all of the DOT exams, and we'll talk about that in a little bit further down the talk. The determination of operator certification is still up to the individual examiner. There's a lot of leeway in terms of the clinical judgment and expertise that would allow someone to be certified, and the DOT is squarely putting that responsibility on your shoulders, one of the reasons that they have initiated the training. Certification is required, and obviously they ensure that you have a testing environment that's all secure and all those kinds of things. Basically what it means is the test isn't done anywhere but a certified testing center. They can be done at Iowa State University, which is a certified testing center. Right now they're being done in Des Moines, I think at one of the learning centers down there. It is an internet-based test. It's about an hour or so. It's really not the biggest hurdle in the world, but it is something that has to be done. Other issues regarding the certification is that you will receive this registry number, and I'll show you where that applies. The registry is an electronic means of doing auditing on the DOT exams, not only that you've performed, but also the quality of the exams you've performed. The certification is good for 10 years if you keep the additional CEUs up. Of course, with any credentialing issue, there's reasons that you get put on the registry and reasons you can be taken off the registry. In order to maintain your licensure and maintain your part of on the registry, you have to maintain the medical examiner certification by CMEs. You also have to maintain your other credentialing, such as certifications to pass your state licensing exams, etc. Then they have gone with periodic training. The periodic training can be done in multiple ways. Most of it will probably done via webinar. It also can be done via part of seminars in occupational medicine or even family medicine. They have means to remove you from the registry, of course. The biggest one is that on the audits that are performed, that they think the quality of the examination and the people being qualified really don't meet the standard. So basically, you went to class for 16 hours and you didn't learn anything, and you're still qualifying people that shouldn't be qualified. That's really the biggest reason for removal. The other big reasons are predominantly compliance with the registry requirements. The registry does require that you submit via electronic format on a monthly basis the copies of the DOT exams that you've performed, as well as your registry number. Procedures for removal, well, what they create, they can take apart, I guess. I can't imagine that anyone would be threatened to be removed from it unless there's some egregious act. Reinstatement policies. Again, this is kind of dry, but I will tell you that the reinstatement policy is predominantly that once you're removed, you can't reapply for 30 days. This is predominantly to ensure that those individuals that may have been removed for failure to perform CME reasons have some kind of punitive action taken. Well, that's pretty much the requirements and part of the regulatory side of it. We can talk now about what's going to happen actually in the medical exam. And again, the same things that held before in terms of how long you had to maintain the examination in your office. You had to retain a file for at least 3 years. Those things are still there. Again, now we have the reporting requirements that are done on a monthly basis. And make sure that the medical examiner includes their new registry number. This is the front page of the DOT exam. I'm sure that doesn't show up perfectly well, but to those that have been doing these examinations, this really hasn't changed at all. This is predominantly a symptom and disease checklist. There is a spot on here where the driver has to sign that he's essentially providing a legal affidavit. I think they do that because I'm sure none of my patients ever lie to me and none of your patients ever lie to you, but when they try to maintain their work, sometimes they'll lie to the DOT. The screening issues are pretty much unchanged. Seizures, of course, are immediately disqualifying. Diabetes can be disqualifying. There are exemptions for it. But you're looking for heart disease, lung disease, hypertension, etc. This is page 2 of the DOT exam. Also, it is unchanged from previously. Documentation regarding the visual acuities. Monocular vision has to be noted. There are waivers for monocular vision, a few of them still out there, and there still are exemptions that can be performed. Hearing testing, which is always interesting to me, how anyone can actually do a forced whisper test. I'm not sure that I can do one accurately. We almost always rely on the more advanced testing where you're actually looking at the decibels, not a formal audiogram, but a screening audiogram. And then there's blood pressure issues. If any of you have been doing these, we all know that just a few years ago, the DOT instituted screening for hypertension, looking for individuals that had elevations in blood pressures and ensuring that not only was it identified, but that it was treated in order to maintain their certification. That again is felt to be significantly a significant risk when you're operating a motor vehicle for sustained uncontrolled hypertension. we could go through the various reasons, but basically for people above a 140/90, they can be conditionally provided a DOT card for a period of 3 months. So can individuals with blood pressures of between 160 and 110. Individuals over 180 to 110 can't even be given conditional DOT cards. They have to be treated, and then once their blood pressure is controlled, then they can be given a conditional DOT card for 3 months. Once an individual is being treated for high blood pressure, they require annual examinations rather than 2-year examinations that other individuals are eligible for. And again, really, none of this has changed with the new regulations. This is the physical exam, which we'll go through in a little bit. Again, this form has not changed much. There is the conditional qualifications down here and the issues regarding waivers and exemptions on this side. This is what the new DOT card looks like. It's not vastly different from the old one. It does have the National Registry number that has to be put in with each exam. It also has the idea about some of the monocular vision waivers and exemptions require intrastate driving only, and that's not truly what that means. Intrastate actually implies that the cargo that they're hauling is within the state. It's not coming from out of the state. Even interstate truck drivers may only operate within a state, but their cargo comes from outside it, so they're considered interstate drivers. The other thing that is a little different is this whole idea of CDL. Keep in mind that the CDL system is controlled by the DOT. It's not really a medical issue. It has to do with the weight of the vehicle the individual's operating, and a simple checking yes or no is all that's required for us, and generally the individual driver will tell you whether or not it's CDL. The physical examination really is unchanged. You're, of course, doing a general examination. The urine test is required. Vision screening is required, along with color vision testing. The idea of monocular vision. I rarely see anyone driving anymore with a monocular vision waiver. There's still a few of them out there. Height, weight, blood pressure, and this idea of referral to a specialist that we'll talk about. The physical exam. The real addition is that we now need to document someone's BMI, someone's neck circumference, and do a screening for sleep apnea. That has become a very big issue in the DOT world. As you can imagine, single vehicular accidents, meaning that there is no other accident involved in a semi-tractor trailer, almost always occurs because the driver fell asleep. And those accidents tend to occur at high speeds over long distances. They have very high fatality rates, and unfortunately, commonly accompanied by other individuals that aren't operating the vehicle being killed or injured. So what we use, and this is entirely up to the examiner, what we use in my office is the Epworth Sleepiness Scale. This is basically a screening form that the driver fills out and hands us. It's just a screening about how they feel when they're sitting and watching television, reading, etc. It's a way to get an idea as to whether or not they have sleepiness when they're not otherwise engaged. We take that in accordance with the BMI, and we'll talk just a little bit about sleep apnea again further. That is, again, not mandatory. That is something that is done in my office. I would recommend it to anyone in the McFarland setting that is going to use it. These forms will be available to you. I would definitely use it, put it in the record, scan it in, because if it turns out you're seeing someone with a BMI of over 35 and a neck circumference of 18, and they say they have no sleep apnea issues, you may be asked to explain why you didn't demand screening. Health counseling is also one of the new parts of this examination. It's always kind of been done on the side by just the examiner talking to individuals about their general health. But there's a big push to look at talking to drivers about medications and non-disqualifying medical conditions that may require treatment. Particularly, there's a push to try to identify individuals that are taking potentially drowsy and or sleep-inducing medications while they're driving, predominantly antihistamines, although it can also be side effects from other medications. The other thing is they're wanting this documented as part of this new training, and you'll see that we've kind of developed a form as a way of also doing that doesn't take a lot of time and doesn't require a lot of interface. This is a one-page, a front and back-sided document that actually is an education page for the driver. It talks about prescriptions and over-the-counter medications. It talks about common side effects. This is a partial list of legal types of medicines that can induce drowsiness or impair your ability to drive, reaction time, etc. The other side of this talks about how to read their prescription forms, talks about medical drug interactions a little bit, and then it has the most important issue is that they acknowledge that they've read it, they understand it, they've had the opportunity to ask the examiner about any issues that they have, and that by signing this, they have now, quote unquote, been counseled regarding these issues. It is not something that I've found to be much of a hindrance in terms of trying to complete the examination. Most of the individuals are pretty much aware of it to begin with, but there is, again, this new push by the DOT to ensure that they have been counseled. And then there's some things that are just kind of common sense to probably most all of us, but let's keep in mind that some of our truck drivers may not have the same common sense. It's things like you tell them if they're required to wear corrective lenses that they actually have an alternate pair of lenses with them, particularly when they're on the road. If they wear hearing aids, they need spare power sources. If they have a history of DVT, you talk about the risk of inactivities. Again, this is trying to push that DOT exam into being a little more comprehensive primary care type of counseling format than it has been in the past. It also talks a little bit about corrective actions for conditions. Not very difficult. And I apologize, this slide was duplicated, but the other issue is planning for dealing with, we have a diabetes and glucose monitoring. See Dr. Carreno in the office here, and he loves doing the DOT certifications. But the diabetics on the road are multiplying as the number of diabetes has become much more prevalent in our society. When we have individuals that are diabetic driving these vehicles, we're pretty much required to ensure that they're either taking their oral medicines and monitoring their glucoses, or B, they have the appropriate insulin exemption, or C, that we have talked to them about diabetes and self-monitoring if they're on dietary control alone. Again, these are considered obligations of the examiner now, and individuals that are diabetic should be informed not only of these issues, but also the fact that they've been counseled, and it should be documented. The whole idea of the DOT exam is the fact that an examiner is going to decide that an individual is capable of operating one of these massive machines, so that they obviously have to have the ability to bend and climb. They have to be able to manipulate. At one point, the DOT became so specific in what their grip strength had to be that they actually calculated the exact angle that someone had to have at the PIP joint in order to grip the wheel and the exact force that was required. And then that kind of went out the door when power steering became available. So some of this is very redundant, but it should be considered. The individual has to be able to get around the tractor trailer. And when I see particularly the older truck drivers coming in, I always kind of shudder just a little bit, because some of them have a great difficulty either with degenerative conditions in the spine or the legs that would prevent them from really being able to get around and get under some of these vehicles, despite the fact that they've been doing it for 30 years or more. Something that they are educating more about is that they want the DOT examiner to talk to the individual about the progression of certain degenerative diseases, degenerative conditions. The physical examination has always required a certain amount of range of motion of the joints, a certain amount of functional testing, squat, recover, heel toe walk, those kinds of things. When you see your older DOT truck drivers and their severely arthritic knees, it's a good time to talk to them about considering orthopedic evaluation. Some of them do very well with knee replacements. It's certainly not disqualifying, and you actually improve their quality of life with that discussion, despite the fact that they may think that you're holding their livelihood over their head. Disqualifying conditions really haven't changed much. Any history of epilepsy is disqualifying. Diabetes requiring insulin is not necessarily disqualifying, but it does require an exemption. We can go through that a little bit, but basically it requires that the individual be examined and treated by an endocrinologist, that a 5-year history be performed. The endocrinologist must sign off annually on the fact that their diabetes is controlled and they're having annual eye exams. And then they have to have the DOT exam annually as well to look for any other conditions that may be disqualifying. Failed vision testing, unless exempted, again, there are individuals that get exemptions from monocular vision. Otherwise, they have to meet 20/40 in each eye. Hearing below standards with a hearing aid is something that we rarely see. Most people are able to meet the standard, which is predominantly 40 decibels in the better ear in the speech ranges. Any individual taking methadone, and why they picked methadone years ago, I'm not sure, but any individual taking methadone is disqualified from operating a DOT required vehicle. I can certainly think of a million other drugs that ought to meet that, but the disqualifying factor has been put at methadone. A current diagnosis of alcoholism, something that is very difficult to screen for in the examination, and controlled substance abuse. This is part of the drug screening part of the DOT exam. Not all the DOT examiners actually do that section of the examination, but that essentially unlinks the drug testing from the exam. This portion would be dealt with by a medical review officer if the individual who came in for a DOT exam had a drug test and failed it, could not produce a prescription for any of the controlled substances, or they have a Schedule I drug in their system. Driver disqualification, again, is placed squarely in the hands of the examiner. It's not something that you can necessarily call the DOT and say, can I qualify someone with X, Y, or Z or not? Commonly, they won't have an answer for you. There are a couple of handbooks that are sometimes helpful. I tend to get multiple phone calls from various providers that are dealing with complex DOT exams, and it does come down to clinical judgment in many regards. If you feel, as a DOT examiner, that they have a condition that would impair them from operating the vehicle, don't qualify them. You can always ask them to get another opinion. You can always tell them that you'd prefer that they be seen by someone with more expertise or more training. Keep in mind that there is a certain amount of liability that goes along with that. Just so that we touch on the new requirements for screening for sleep apnea, this could be a whole lecture in and of itself, and I'm sure there's people here that know a whole lot more about sleep apnea than I do. But this actually came about with the regulation changes last year. Obstructive sleep apnea diagnosis now precludes an unconditional certification for a DOT exam. A driver with untreated obstructive sleep apnea and an apnea-hypopnea index of less than or equal to 20 and having no excess sleepiness during wake periods could be given a conditional certification. A conditional certification just implies that it's much more limited in terms of time. Basically, we're treating obstructive sleep apnea a lot like they started treating hypertension a few years ago. Any individual that is treated for obstructive sleep apnea and is a DOT driver has to show documentation that they are being treated for it, they're being compliant, and that they are going to be examined more frequently. The recommendations that have been provided are predominantly for those individuals that are that have been tested, and in fact there is a brief slide in here about testing that's available. The standard polysomnography is always recommended rather than any of the other less monitored settings. It does require that individuals be recertified annually. They must document their acceptable compliance with some type of pressure BiPAP or CPAP for at least 4 hours per day, using it 70% of the time. To those of us that see these commonly, we'll get a printout from the memory card of the machine, and it will tell you how often the individual is using it and to what degree. Again, this is the recommended minimum standard. Most of the people that truly have sleep apnea really like the sleeping better, so they're mostly compliant with it, at least the ones that I see. Optimal efficacy is 7 or more hours per day, and that's probably more along the line of what I would see. There is a proposal for immediately disqualifying an individual who provides some documented evidence of sleep apnea. That may be the screening questionnaire that was provided. It may be, and I've seen this before, where the individual says, yes, I have obstructive sleep apnea, and no, I won't use my machine. Or my machine's broken, I haven't had it fixed, or I haven't seen my doctor, and that's a reason to disqualify them. And I've done that. It doesn't make people happy sometimes because they lose their income for a period of time, but it does meet the requirements. It does. It is consistent with the new regulation. I don't think that I'd want to wait for someone to have a crash associated with falling asleep to disqualify them. So again, anyone that's non-compliant or really is unwilling to be tested, I probably won't qualify. In doing the screening during the examination, it's important that we look at BMI. It's also important that we look at neck circumference, and there's a slide about that coming up. But when their BMI is over 35 in an individual, and particularly in a male with a neck circumference of over 17, that's an individual that probably ought to be screened, whether they admit to any daytime sleepiness or whether they admit to their wife kicking them out of bed for snoring, etc. Under the DOT regulations and the new requirements, if this individual document that they have a BMI of over 35 and a neck circumference of over 17, and you don't recommend a sleep study, if there's a problem, that could be an issue for you to deal with or at least answer to. It could also get you taken off of the registry. So it's not something that we can look at lightly. I will tell you that it's not a very comfortable conversation, particularly with younger people. I see many highly overweight young men between the ages of 35 and 45, and when you talk to them about having a sleep study done because of their weight, and they really don't want to deal with it. Sometimes the only way to get them to actually be evaluated is to, in their ability to drive. So the screening that has been proposed is pretty much what we go by. BMI of 35 or above, symptoms of OSA. They have risk factors that you may or may not completely identify. Those include hypertension, type 2 diabetes, hypothyroidism, family history, postmenopausal women. I really don't want to wait for them to have a single vehicle crash, but those issues are enough that I would propose that they should be screened prior to be giving an unconditional card. Again, I would recommend the in-laboratory polysomnography. There are some other ways of doing this screening that can be done. The FDA has approved this limited channel testing device. I'm not very familiar with it and don't think that I would necessarily endorse it, particularly when we have in-laboratory polysomnography available. One of the things that you can always do if you have a question about obstructive sleep apnea in an individual is just refer them to someone that deals with it much more frequently than you do. Again, I would do that in conjunction with either a conditional period of certification or no period of certification. It does prompt them to get evaluated. and then they can deal with all of the titration and ensure that they're actually being treated properly. They have written out some additional requirements regarding obstructive sleep apnea. Again, the minimal compliance. There are other ways of dealing with it also. Bariatric surgery, original facial bone surgery, and tracheostomy. All of those things can allow the individual to be recertified without CPAP or BiPAP. Again, it does come up to the discretion of the examiner. At this point, I kind of left this open for questions and opinions. I will tell you that I can only give you opinions because commonly in dealing with the DOT and all of the federally regulated programs, you find out that there aren't really any straight answers for whatever clinical scenario comes up. And it does require that the individual examiner use a lot of clinical judgment and hopefully understand the work environment and avoid penalties and injuries. So I will open it up for questions.
Question. With the experience, I think you said that sleep or drowsy problems are a major source of crashes.
Correct.
Or is there any significant technology that can be applied to these trucks that will sense drivers becoming sleepy and impaired?
Well, I'm sure if we watch television, you see a commercial for, the Mercedes-Benz commercial that now says that if you're driving your Mercedes-Benz, it'll wake you up if you start to go off the side of the road. I don't know of any commercially available technology that will do that. I certainly don't know of any that is being used by any of the interstate truck drivers. So I guess my answer to that is, first, I probably don't know, and second of all, I haven't heard of any of it, so no.
Yeah, so that whole issue about obstructive sleep apnea and sleepiness is very complex, and my experience so far has been that the Epworth Sleepiness Scale doesn't help because the Druckers know by this time that you're dishonest with those things, so you just fill it out anyway. The thing that has done in vis-a-vis what Dr. Bannett was asking was in France, what they do is they have a way of monitoring how often the vehicle goes across the median strip or one of those types of devices as an index of sleepiness. And the whole issue is, you can have obstructive sleep apnea and not be sleepy. It is possible, right? So you struggle with the whole manner of how do you determine if somebody is sleepy. And that's where we do things like the multiple sleep latency test and the mean wakefulness test, all of which just adds more money and complication and difficulties. The FAA definitely wants those kind of tests on the books, and I guess if you're a clinician and you have a person with mild obstructive sleep apnea who really doesn't want to comply and you're not sure what to do, you can always have the lab do a mean wakefulness test, which requires them to sit them in a dark room for 40 minutes, and we measure whether their brain goes to sleep or not. And there's means and normative data for all that. 4 naps in a day, or 4 40-minute sessions. So those are some other things you can do if you get pressed to deal with it. But it is a huge issue, and I'm very grateful. And I think what you outlined already is very simple. BMI neck circumference. BMI neck circumference, you got to do something about that. You got to chase it a little bit.
Thank you for your comments. I completely agree. And again, the federal requirements that are being put forward really have made a huge emphasis on identifying particularly your independent over-the-road truck driver with sleep apnea. If there's any way to identify them, they want them off the road or treated. I mean, it's just simple as that. And again, what Dr. Spencer is saying is, if you have any questions about it, ask for specialty consultation. We have it available. Any other questions? Yes. Costs related for certification, predominantly for the DOT exam portion, there's a standard fee for it. I will tell you, with the advent of the National Registry, it increased the occupational medicine costs for doing the exams fairly dramatically. It almost doubled the cost of the examination. The other costs that go along with being a DOT driver are entirely up to the state and all of the other driving demonstration and those kinds of requirements, which I'm not familiar with those costs. But the cost for any additional medical screening is entirely borne by the individual. It's not shared by anyone. Yes?
So this is going to take a fair amount more time for us to do. Is the charges or the E&M code any different? Or?
Well, we have adjusted our fees because it definitely increases the amount of time that is required to do a DOT exam. I would agree with Dr. Spencer, the upper sweeping the scale is probably worthless other than the fact that you've made the individual sign it, because there are civil penalties for individuals lying about their medical history. And these people are being watched. That's why they put the National Registry together. They are going to do audits, so there's other reporting requirements. Yes, there's no change in the E&M code that I'm aware of, but yes, the cost is definitely higher.
Like you, I'm often frustrated with the DOT with their lack of standards. If they give me something, I can give them an answer, but they have this big nebulous cloud. So my question is specifically about visual fields. Okay. So how do you determine a visual field?
We determine visual fields usually using the TITMS screening machine. I don't do manuals. I used to be in a setting where I had to do those. As far as I'm concerned, they're not very good. You stand behind the individual and, when can you see me, and look straight ahead. And it requires a lot of their cooperation, and there's a lot of subjective interpretation to it. I would recommend that it be done via TITMS machine. It's been at least reliable as anything else. Certainly it doesn't take the place of, formal visual fields done by the ophthalmologist or something. But yeah, and I will tell you just a comment about the frustration with the DOT. I happen to know the individual that has worked with putting together these requirements and worked with the federal government creating this whole thing. And she is just as frustrated as we are because they don't have a true codifying body. They don't have a medical hierarchy like the FAA does that allows the individuals that are out here, doing examinations, millions of them annually. And they don't have anyone to ask a question about. They've essentially left it up to the clinician. But yeah, I understand your frustration.
I missed the beginning. If we want to get certified to do these exams, where do we get tested?
Well, first of all, you would need to take a course either through ACOM, the American College of Occupational and Environmental Medicine. If you have any questions about it, I'll be happy to forward it to you. There are other certification training programs out there. One of them is named Oakstone, which is done via the internet and via handouts and materials sent to you. The testing is done at a certified testing center, and what you do is you call the registry in advance. You make arrangements to take the test. There is a fee for it. You go to the testing center and you take the exam. And then they will tell you whether or not you passed it, and they'll send you your registry number.
How long is the course?
16 hours of pretty much in-class settings, 2 days.
Okay, that answers my question.
$800 for the course, yeah, minimum, pretty much. Yeah, I'm trying to avoid that. Otherwise, all I'll have is a DOT department. I won't have an occupational medicine department. Any other questions? Thank you very much.